Nakikita na tayo sa live chat, no?
Good morning, Dr. Asbun.
Good morning. How are you? Good to see you.
I'm good, sir. Thank you. Good to see you too. Keep safe.
Thank you. You too.
Hi. Horacio.
Hold on one sec. I cannot see you. Oh my God, who is that lady? You grew up. Hi, good to see you.
Hi.
And the little dog. How are you doing, Joy?
I'm good.
So good to see you.
You
Is
too.
mom behaving?
She's not eating.
Mm-hmm. I'm gonna have to take care of that. The dog is not eating?
They're having dinner. Joy is having dinner. Okay, pakibigyan
Oh, okay.
si Dr. Filona ng background.
Yes, Doc. Sending na po sa kanya.
Tsaka si Dr. Buenafe. Tsaka si Jonathan. Supposedly nakuha nila. Joanne.
Doc, sending na po sa kanila.
Si Ray is here na pala.
Present. Present. Present.
Got it.
Hi, Horacio. Paano ba maglagay kasi ng background?
Sabihin mo kay Dr. Buenafe. Dun sa left hand corner sa may Zoom sa taas. Click mo yung preferences, nandun yung virtual background. Horacio, you should put out your Sage's background.
Doc Allen, may sinend po ako sa Viber nyo, pati instructions. May photo po doon.
Ako ng picture nung There you are. I saw it. Okay.
Nakita niyo na, sir? Apo.
Download pa lang. Marunong ako magkabit ng virtual background eh. Wala lang ako ng picture nung PAHPBS at saka PALES.
Nasend ko na rin, sir. Nasa Viber nyo po.
Sige. I-share ko sana.
Hindi ako marunong nun eh.
Download pa.
Pwede, sir. Save nyo lang po.
There you are. So,
No problem, sir.
okay. Wala lang ako ng picture nung pag-see sa PALES.
Na-send ko na rin, sir. Nasa Viber niyo po.
Saan nakikita yon?
Pwede, sir. Save niyo lang po. Doc Ray, sending you po. Thank you.
Sa Viber yon ano?
Yes, sir.
Okay.
Ah.
Okay.
Yes, sir.
Nice na. Success.
Okay na, sir? Okay. Doc Ray,
Ito.
na-send ko po sa Viber
Okay
niyo yung
na.
instruction.
Okay, saan siya sinisave?
Sir, save photo niyo po. Laptop yung gamit niyo, sir?
Yep.
Opo. I-transfer niyo lang, sir, yung photo doon sa files niyo. And then, yung instruction, sir, na second photo, nandun yung virtual background settings.
Okay. Wait
Apo.
Photo. More? Nasa more ba yon?
Nandun, sir, sa may near start video.
Stop video. Video settings. Choose virtual back.
Yes, sir.
Okay, plus. Ito na lang.
Sir?
Ito na lang. Add image. Yun na, nakita ko na.
Okay, sir.
Di ba pwedeng galing sa ano? Desktop. Yun. Ang pangit, para ako may anencephaly. Oh? Oh? Oh?
Okay, hindi kaya sa tablet, no?
Sir, parang depende sa iPad nyo po. Kung
Depende
anong
ata sa Kuya John.
iPhone.
Naka-iPad ako.
Sir, bago yung iPad mo.
Hindi. Pero bagong model.
Yun yung sir. John, bili ka na daw ng bago.
Hindi siya bago, pero bagong model.
802 na.
Ha?
I don't think it's working, is it?
Start ko na, Doc,
Morning, Aracho.
Good morning. How are you?
I'm good. How about you?
I'm doing very well. It's a great idea you did this.
Hindi siya bago, pero bagong model.
Okay, so we're now going live. The attendees are now able to see us. I think we can start.
We should start.
I don't
Okay.
I don't have the picture part
So let's start.
that I normally had. Yeah, it's okay.
So good evening, everyone. We'll start with the opening prayer from one of our board of directors, Dr. Ramon de Vera. Microphone, please.
Somebody needs to activate, the host needs to activate his
Will
microphone.
abide in the shadow of the Almighty. I will say to the Lord, my refuge and my fortress, my God in whom I trust. For it is he who delivers you from the snare of the trapper and from the deadly pestilence. Blessed are you, O Lord our God, King of the universe. We bless your name, our Heavenly Father, for you are sovereign over all your creation, over each one of us, and even, Lord, you're sovereign even during these times of the pandemic. We know, Lord, that you have a purpose in all these things. We thank you also, Lord, for making our meeting possible tonight. May you bless and grant us success tonight, O Lord. May you bless the organizers of this event. Our Heavenly Father, we remember our departed colleagues who succumbed from the COVID infection. We thank you, O Lord, for your good sovereign will over them, O Lord. And we remember their loved ones, O Lord. May you give them strength and comfort and hope during this time. Our Heavenly Father, we commit this meeting into your hands for your glory. In Jesus' name we pray. Amen.
Amen.
Good evening, everyone.
Good evening.
Okay, Alvin, please play the next video.
Alvin.
Okay, good evening, everyone. This is the impact of COVID-19 on innovations and planning in surgery. This is in collaboration with the Philippine Association of Hepatico-Pancreatico-Biliary Surgeons and the Philippine Association of Laparoscopic and Endoscopic Surgeons. To give the opening to the welcome remarks, may I call on now the President of PALES, Dr. Ernesto Tan.
Can you hear me?
Yes, sir.
Hey, good evening, everyone. And good morning there, Professor Horacio Asbon. Thank you for accepting this invitation. Welcome to the first PAHPBS and PALES webinar with the theme Impact of COVID-19 on Innovations and Planning for Surgery. With this pandemic, COVID-19, our so-called routine activities and lifestyle has totally changed. From the time we get out of our home, going to the hospital, if and when you need to go to the hospital, to the emergency room or operating room, and going back home, the so-called routine is totally different. And so as the teaching, training, learning aspect definitely are also affected. In time of uncertainties, when the ECQ will be lifted, PALES together with PAHPBS thought of this webinar, which we hope PALES can do this 2 times per month, either solely or in conjunction with different specialties, with or without foreign experts. We have posted in our website and FB page the guidelines with infographics regarding lap and endosurgeries to serve as a guide relative to our existing capabilities and logistics. We have also released financial assistance to our 7 chapters and 14 accredited MIS training institutions in Metro Manila. Our annual convention this July 2020 is definitely postponed. Maybe we will hold this on December 2020 together with PCS annual convention, depending on the situation. Although there were some glitches in the first webinar of PCS and ELSA a week or 2 ago, hopefully these are addressed and remedied. This webinar is somewhat novel to us, and please allow for some glitches also, if any, but hopefully none. This, as you all know, is very dependent on internet. We were not spared of casualties from this monster as frontliners, and particularly one of the casualties was a member of the board of PALES. A fallen hero, Dr. June Resurrection, a pediatric surgeon. We will surely miss him. Rest in peace, my friend. At this point, allow me to acknowledge Madam Prexy of PAPSI, a member of PALES board, Dr. Kate, together with Dr. Jeff Domino and Dr. Monet Supang, who were working hard during this time of pandemic. And of course, to the board of PAPSI and PALES for their support and encouragement. Also to TNP and Medtronic for their support. Maraming salamat po. Once again, welcome to the first PAPSI and PALES webinar. Be safe and healthy. Stay at home. Go to the hospital only if it's necessary. Together, we will beat this invincible monster. Good evening to all.
Thank you, Dr. Tan. Now to give her welcome remarks, the President of the Hepatico-Pancreatico-Biliary Surgeons, Dr. Catherine Te.
Thank you, Mon. Good evening, everyone. Welcome to this webinar. Thank you very much, Dr. Tan, for that heartwarming welcome remarks, and you've made my job really easier now. Dr. Tan has really opened the floor and the momentum. So I together with Dr. Tan, the rest of the board of directors of PAHPBS and PALES, and of course with other society, Philippine College of Surgeons. I welcome all of you to this webinar tonight, and of course our very special guest, Professor Horacio Asbon. Thank you so much for joining us all the way from Miami. It is 8 in the morning, and thank you so much for joining us tonight. To everyone else, I hope this will be a good learning platform, something that will be different from the rest of the COVID talks that we have heard. So without further ado, I would turn this to Dr. Asbon for a few words. I would really like to thank our sponsor as well, Medtronic, for making this happen. And truly, COVID-19, this period has made us stronger and showed us what solidarity and resilience means. So, Dr. Asbon, we will be very happy to hear from you.
Thank you very much, Dr. Te, Dr. Vera, and several of my friends that I can see in this. First of all, congratulations both to the Philippines Association of Surgery as well as to PALES and to the HPV Society for this initiative. We have learned through this crisis that this is a very good way to reach out to our colleagues, to be able to share, exchange ideas, and at the same time learn about this disease that has affected us all in many aspects, from doing surgeries to the fact that I had to shave to be able to put my N95 mask. Then this is just an illustration of how the world has changed in less than 2 to 3 months. Asia was hit first, and unfortunately, several of our countries did not learn from that. Some countries in Asia did learn quickly, and we have now to go through a very tough lesson. Nevertheless, I agree with the words of introduction that had been stated. Together, we will overcome, because human resilience is not to be discounted. And this seminar is a show of that. We adapt, continue, push forward, and eventually we will succeed. Thank you again for the invitation. It's an honor for me to be again among you, colleagues from the Philippines.
Thank you, Professor Asbun. Kathleen? Yes, okay. So to start this, the first speaker is Voice from the Frontline. Please welcome Dr. Kathleen Chua.
Hi, good evening, doctors. My name is Dr. Kathleen Chua, and I'm here to share a few of my experiences and thoughts as a surgeon at the front lines during this time of the COVID pandemic. Just a few disclaimer before I start. As surgeons, we all have undergone training, fellowship, then years of practice to be able to make us a confident surgeons that we are in our own fields. However, none of us have trained surgeon in a time of a pandemic. So dealing with something like this is something very new to all of us. So whenever we enter the operating room, it used to be that we only think about the operation we will perform on the patient. But now there's a new added layer of fear and anxiety for our own safety. If I operate on this patient, will I be okay? If after this OR, will everyone in this room be okay? And how do I effectively communicate my healthcare plan to the patient or their relatives if communication in itself is difficult during this time? But now we have no choice. But we all need to move forward despite all these difficulties. The situation we are now is now called the new normal. And this new normal has made me more resilient and accepting to changes. And one of the most obvious changes that we have is, the donning of the PPEs during the operation, which is not, which looks cool, but putting it on is not. And if you think that's the end of the story, wait until we go inside the operating room. My consultant once said it's like being an astronaut inside a microwave, and I totally agree with him. So basically, these are all the complaints in the OR. Just to summarize, it's not really the most comfortable thing to wear, but we are all coping up with it now. And aside from the PPE, the operating rooms right now and the equipment are being upgraded. UV and suction filters, negative pressure rooms, all of these will be discussed by our panelists later, so stay tuned. But we are surgeons and we find ways. And this is a very good example of what we are doing right now, the online surgical conferences or webinars. These make learning possible while still maintaining social distancing. And aside from the learning from these conferences, surgeons also use this platform to make policies for their own hospitals or institutions. So in a way, we have all become a little bit more techier. And it's a good thing to learn something new. Also, frontliners, specifically, this applies to surgical residents and fellows. They have revised their duty schedules, even their duty posts, to be able to maximize resources and manpower according to their institution's needs. And the situation is hard, and we have colleagues who have succumbed to the virus. But at the end of the day, we must get back on our feet and do our jobs because people need us. Each healthcare worker is essential in this war. This pandemic has also taught me the importance of gratitude, even in the smallest things. And to this, we thank all the doctors who always ask how we are, sending us PPE, food, coffee, cheering us with kind words. Indeed, these small gestures can make this situation a little bit better. So thank you everyone for everyone's hard work, and thank you very much for your attention, doctors.
Okay, thank you, Dr. Kathleen Chua. So for our next speaker, we have Dr. Catherine Te.
Thank you, Mon. Let me just share my screen. Okay. Alvin, is the screen on? Can you see the screen?
Yep.
Okay.
Yep.
Okay, so tonight I will talk to you about the impact of COVID-19 on innovation, so surgical preparedness. The current data that we have shows as of April 21. This I haven't uploaded. I haven't changed this, but we know that the cases have been more than 6,800. When this will stop, when the curve will flatten, but certainly we hope that it won't be too long. And as everyone has mentioned earlier, everyone has tried to cope with the current and on the situation in various different ways. And you will also see that creativity such as this has also been developed during this time. So this is an art piece that was made by a nurse. Her surname is Magbanwa, and she's from a nurse she's from one of the provinces down south. So it's a beautiful rendition of surgeons at work in the Philippines. So this is the latest as of yesterday. The confirmed numbers of COVID positive patients are 691. And we have 462 deaths. And of these, more than 25 are, at least 25 are doctors. We look at all the different aspects in terms of the impact of COVID-19. And this is one of the papers authored with a few friends globally. And we looked at the immediate and the long-term impact of COVID-19 in the delivery of surgical services. And the truth is that we'll never know what the long-term impact is. So we really have to follow up in the next 3 to 5 years what actually happened to our patients during this time, the collateral damage that it has brought about. Because we know that during this surge, surgeries were canceled, and during this time in the beginning, there were absolutely no strategies. everyone was just told to stay at home, and we were crippled as surgeons. Surgeries were totally canceled, and our patients were um, given notices, and in fact not knowing the next day. So the threshold for such a given healthcare system may actually be broken by the surge of this pandemic, and the capacity to maintain even life-saving surgeries such as cancer surgeries may not be sustained during this time. And this leads to a potential additional loss of lives, which is unrelated to the pandemic, but we call it as the collateral damage. And mitigation or suppression of strategies may be long lasting and have effects on the elective and semi urgent capacity. It has a big impact on prognosis. So we hope to follow this up and see what's really going to happen in the next few years to come. And we hope that the curve is going to come down very soon so that we can resume our elective surgeries, our cancer surgeries, and our day cases as well. And during this time, a multitude of data, of information, of rapid reviews, and everything else on the internet that you can download and you can read. And there is too much information, and some of them didn't have enough meaning. And we all have to act very, very fast to be able to cope with the current situation. So sometimes it's very, very hard, especially coming from the societies, from the leading societies, trying to guide everyone else what to do when people are not so certain in this time. So here in the HPB, in the HPB Society, as well as in PALES, we came up with recommendations to help everyone have something to fall back on as a guide as well. And the board has really been busy. We have been meeting, and we have calls here and there, and like Viber group chats, just like everyone else does. But we try to focus also on these different guidelines that we can offer for everyone's needs. First, I'd like to say that it is very important to manage the surgical system. And this is a paper that was published by Gawan in the very, very beginning of the pandemic. And truly, it has given us so much thoughts up to how we should change, or not really change, reorganize or restructure our systems. And we are learning daily, trying to improve on what we have already started. And every day we try to see whether it can be better for everyone. It is important to have a dedicated command center so that everybody will be updated, and everybody will have some definite tasks at hand and contribute to the collaborative work. So each hospital, definitely, I'm very certain each hospital has their own command center, and each of you have been really working very hard to sustain this challenging period of time. So what we have currently encouraged is to alter your systems engineering, and have team briefing all the time, and organize team competencies. And of course, with these, you can now prepare for action. So for example, in the operating theater, in the beginning of the surge, we gathered everyone, and we brainstormed, and we how we can improve our workflow, our paths, especially trying to differentiate the COVID path from the non-COVID path, and opening up operating theaters, and also trying to understand the new normal, which is the donning, the doffing, and all those systems or processes that we never get used to. And we had to be very vigilant every single day because there are so many changes, and we had to innovate because a lot of things are not readily available. So these are the processes that we have been doing, really going into not only just the processes but looking at the engineering systems, everything that we can do, trying to help each other out. So we have come up in HPB to help us be help us understand also, and have a path with this 10 we thought about 9 something, and I added a 10. So first we need to prepare our workflows and prioritize emergency and urgent cases, followed by those whom you have canceled during this period, and triage them as they come. Patient selection is key, and we need to provide communication and reassurance to patients. Having a pre-procedural checklist would really help a lot. And you need to protect yourself and your entire team during this period. And during your surgery, prevent and mitigate surgical smoke, manage the pneumoperitoneum in laparoscopic setting, and post-procedural debriefing, sterility process, and documentation are now important procedures that sometimes we take them for granted. And of course, the 10th is post-operative management. How do we address this to our patients? So first we need to prepare the workflows. So during that time, to really reorganize, and many of the hospitals do the same, and St. Luke's also used this path adapted from Singapore. So trying to give each one their specific tasks, and keep this task at this certain period. So all of these will be are prescribed and expected to be implemented. For example, the transport of patients are now very different. In the past, they just wait and lie there in the hallway or in the recovery room waiting for their cases to start. But now we don't do that. The patients are activated, the guards are activated, and the patients are brought down only when we are ready to start. So these are all a lot of changes that are happening, and the workflows really have to change every so often. Pathways have changed, and you will see that a lot of signs are everywhere. No entry here, no exit there. So these are all something that we have to get used to. And we have innovated ways, for example, having a foot bath that you will see here as you enter the operating theater. You will have to soak your shoes over there before you can get in, and then separate elevators for patients and for employees. And as you go in, immediately you need to change, unlike before we walk through and go into the changing rooms to change. And every single day our nurse do the team briefing together with the residents, and close the paths, the access that should not be open, because we so you can or and then there's no end exit from that. So we have to get used to it, because this is something that we do every day. We enter and exit from the same door, but nowadays we'll have to do the other thing. And we put arrows on the floor path so that we will be guided which and where to go get into the donning area. We have all the signs on the wall, and there is the runner on the outside waiting. And here as well, this is in another hospital where the runner is outside and the things are given over the window. And to get out, you go through this tiny door, follow the red line, and get out of the operating room. So that's how things have changed, and the security officer is there, or the spotter is there waiting for you to doff, and there are clear signs to show that the particular steps and where you should leave all your PPEs. So from the different workflows, we need to look into how we prioritize our cases as well. So we have all these in the guidelines that we have published earlier. So you can just download them and have a look. Now, one thing that is very, very important is patient selection. And we need to create and utilize a multidisciplinary triage system to categorize the essential surgical cases according to these particular risks: urgency based on symptoms and expected progression, the safe postponement period, complexity of surgery, and the length of surgical time, patient risk factors, whether they are cirrhotic, they have diabetes, hypertension, healthcare workers' risk for COVID-19 exposure as well, availability of resources, including blood, surgical equipments, PPEs, etc., ICU, approach to surgery, whether open or lap or robotic, and then, of course, the length of time for recovery and the hospital stay of our surgical patients. The informed consent has also changed because we have included the risk of viral exposure and, of course, pneumonia post-operative and high risk during this time. And we also have to think of alternative approaches to the various diseases that can be postponed. So telemedicine has also gained a lot of popularity during this time, and I don't think I need to discuss that further, but definitely during this time we take advantage of technology and do our multidisciplinary meetings and communication with patients via telemedicine, and also online platforms, learning platforms like this. There are several types of there are different ways to select your patients, and it's really up to you on your institution how you would be able to manage with that. This is one example, using the different tiers and knowing that cancer patients are time sensitive. This is something that we have developed in PAHPBS, deciding whether this case has a lesser priority or a high priority. So we would be able to think and classify the cases. For example, patient that is septic from biliary obstruction, and most likely patient will need early surgery because he will die if we don't do any surgery. So definitely this patient will get the highest priority and first priority to get into the operating room, compared with the other stage 4 widespread liver cancer patients that won't really benefit much if we do surgery. So this is how we can prioritize our cases. There are other different ways, like the medically necessary time-sensitive score, which is a little bit more complicated for me. And we need to provide our patients with the 4 C's, which I call them the 4 C's, meaning that you need to give them context, consideration, and care and commitment. Explaining it to them very well that delaying essential surgery does not mean absence of care. Mainly a paper, a small series that was published in Wuhan, showing that mortality in cases done reached up to 20.5% during this time. And these patients were asymptomatic patients. So it really is something that we need to think of whether we would want to take the risk or not. Pre-procedural checklist is very important. You need to have a COVID checklist prior to surgery. We advocate having a swab for everyone. Philippine College of Surgeons advocates swabbing everyone. And if you are in doubt, do a CT, because the CT would help show some subtle signs and early changes, and a chest x-ray on the day or the night prior. And make sure that you have bloods or equipments, minimize foot traffic in the operating theater. Also include COVID-19 in your WHO checklist, so that everyone will be reminded that it is a COVID-19 case or a probable or suspect case. So I talked about the swabbing, and this is something that we need to be aware of because of the 30% false negative rate of swabbing. And that's why it is important to know when their symptoms happen, or whether the patient result is definitely reliable or not. We need to know that during the very early phase, there is a 30% false negative rate. such that a CT would be helpful. As you see here, very subtle changes on CT makes one suspicious of pneumonia. So you can work up the patient further prior to surgery, or I mean, defer surgery and work the patient up. So again, these are some of the CT imaging that shows you very subtle changes, but they are asymptomatic patients. So we really have to fight our way into this, having CT done for our patients. Anyway, for cancer patients, it's not a big problem because they need to go through metastatic workup anyway. So here, it's important to see here that all these CT scans were done during this time when PCR also were negative, and these were were CT scan findings. And yet these patients developed pneumonia later on. So CT examinations play a vital role in the early detection of pneumonia. May not be specifically COVID-19, but at least helps us work it up. And we need to know that the persistence of these virus on the various surfaces, that's why we don't want to bring a lot of things into the operating room, because they can linger on our stuff. Protecting the surgical team is of utmost importance, and we need to make sure that we have enough PPE and be guided accordingly. There are various videos showing that. And during the surgery, make sure that you prevent and mitigate the surgical smoke. And I won't discuss much of these because Dr. Mendoza will talk about this, but just to show you that truly necessity is the mother of all inventions, because we don't have any smoke evacuation machine. So what we did was just put a slit on the suction tubing and insert the cautery into it. And you'll see that the smoke has been sucked into the tubing during this time. So it's not 100%, but at least it works. And also for the laparoscopic approach, we also try to innovate and do something, making it a closed filtered suction system using what we have in the operating room, such as the vacuum suction bottle, and then the suction tubings, HEPA filter, or the HMA filter of the anesthesiologist, whatever is available. Get all the connectors that you can, connect them together on both sides, and put them into one end into the tubing filled with water, at least 1/3. And the water has a sodium hypochlorite, so that when you suction it, the fumes would go into the water. At least it would collect the viral particles that goes through the filter device. Since we don't have a smoke evacuation system, we don't have a ULPA filter device. Dr. Miguel Mendoza will talk about it later. So you see, this is one way of evacuating the smoke and the pneumoperitoneum. So for example, the aerosol box also, we have tried to design it in a way that it can be used for tracheostomy as well. We tried several ways and fabricated a couple of it just to cater to this type of operation and make sure that we're safe. And pneumoperitoneal management has to be also paid much attention to, and this will be discussed later. And again, the specimens, we try to be very, very careful about it, because this shows clearly that PCR was collected even in the stool, in the urine, and in the blood. So we have to be careful about that. And after the procedure, we have to debrief and document. So this is some of the residents and the colleagues will be familiar with this, something that I've drawn, because this was a procedure for a COVID-19 patient when we did an IJ insertion, and we realized that the positions are wrong, so we need to move, and we need to reposition, reconfigure. So this is the essence of the debriefing and the documentation, so that everyone will be guided and it helps improve the next procedure. So all of these would really help and make our job easier. We make the systems work for us instead of us working for a system. We need to restructure and we organize, design a workflow suited for our hospital and the people that we work with, so that we won't end up in a very fatigued manner like this. In order to protect ourselves, we need to understand that this is a multi-tiered system. And PPE, just having PPE is the weakest and the least effective of all. And that is why a layer of securities like this is the most important, such that we need to use engineering controls and administrative controls as well. So this is clearly outlined here. It's in the advisory that we have published, and also the different recommendations for the PPE use, which you can read in the publication. So to end this, I would say that perhaps this is going to be the new normal in the next few weeks and months, actually. And the QR code there is for downloading the files in here. Make sure that your patients and everyone else would wear masks, as PCS advocates masks for all. In fact, all of us, not only PCS, UH and WHO now advocates masks for everyone. And we all have to be very careful with the way we behave and the way we do things, and try to change the system. And because we want to protect our loved ones and our family as well, and we don't want to bring them back home. So with this, I'd like to end and say that a more detailed talk about this will be happening in the next few weeks. So if you are interested, we would have more time to discuss, as I'm limited by the time now. Next week, we will have a course, a certified course for this. So hopefully you can join us. So thank you, everyone. And I would like to thank the OR team in NKTI in particular for the enormous collaboration from everyone. And we do simulation at least every week. And this was one of the simulations that we performed. And our nurse, Joanne, is here with us tonight. So you can ask her all the questions you want on the workflows in the OR, as we have changed them. We have designed them to suit this particular need. So thank you.
Thank you, Dr. Ate. To the participants, you have a QA box in your screen. You can put your questions there. We will entertain questions after we finish all the lectures. Our next lecturer will be Dr. Ray Sarmiento.
Hi, everyone. Good evening. I'll just upload my slides. Can you see it?
Yes.
Yes, po.
Okay. Good evening, everyone. I'm Dr. Ray Sarmiento, and I was tasked to give this lecture on triaging emergent urgent endoscopy cases during COVID-19 pandemic, a guide to management. So I'll go through the slides one by one, and then questions can be entertained later on. So I have nothing to disclose. And of course, I'd like to say that I'm no expert on this matter with regards to endoscopy during the COVID season. And but I will only rely on the recommendations relaying to you the recommendations of the following societies. The ASGE, the Asia Pacific Society of Digestive Endoscopy, SAGES, EAES, the ACS, PCS, PALES, and PAHPBS recommendations. These are my references, mainly the ones from Sotico and Philip Chu, and personal experiences and communications with the following persons. Dr. Philip Chu, Director of Endoscopy, Chinese University of Hong Kong, during this COVID-19 response in endoscopy in Hong Kong. Dr. Abyssinia, Program Director of our Surgical Endoscopy Fellowship Program, because she was in Chinese University post-SARS. Dr. Ryan Barosa, our head of HPB, because of his experiences with HEPA-B and liver transplantation precautions. And Dr. Edward Roselio, he was immediately in Hong Kong prior to the outbreak of SARS. And he is now head of the Emergency Rescue Unit Foundation in Cebu. And of course, some of my experiences as a Boy Scout during my high school days. I have badges for camping, cooking, and knot tying. That's my only experience here. And the objectives to identify which cases are in emergent or urgent need for endoscopic management by doing risk assessment, to discuss management, endoscopic, surgical, or alternative procedures for these conditions, and to know which type of PPE to be used based on the nature of indication of the procedure. So what are the principles we have to consider? Of course, SARS-CoV-2, there are potential modes of transmission, and usually it's person to person, and it can be through respiratory droplets during coughing or in anesthesia induction, or aerosols generated during endoscopy. And of course, contact with contaminated surroundings and bodily fluid like colonic fluids, or right after farting or saliva on the beddings of the patient. And human-to-human transmission can be seen through respiratory secretions, aerosols, feces, and contaminated surfaces. And we all have to be worried about the virus being viable 3 hours to 3 days on surfaces. And of course, being a surgical endoscopist, we are inevitably exposed to respiratory and GI secretions. And we all know that the risk of infection for the healthcare worker is around 29%. It's not, Wuhan is not the author, but these are the publications coming out of Wuhan. They don't know if it's from the direct care of the patient or inadequate use of the PPE. So as mentioned earlier, examples of person-to-person, it's either healthcare worker caring for the patient or a healthcare worker infecting a co-healthcare worker. Droplets coming from anesthesia or coughing and gagging during endoscopy, and aerosols generated during the endoscopy from air wattle valves of the scope and during the suction and biopsy valves of the scope. And of course, contaminated surfaces and body fluids. So these are just a diagram regarding the possible way of an aerosol generating procedure in endoscopy during induction and during the endoscopy itself. So most of the patients with infected or who are infected with the novel coronavirus 2 usually would present with GI symptoms, half of them. And most common would be anorexia, then diarrhea and vomiting. So there's a potential for fecal oral transmission. So we advise to have our patients have separate toilets from other patients and from healthcare workers. So here comes now the challenge wherein there's a COVID pandemic and we are on lockdown, and we are asked to have guidelines. And we'd like to answer the challenge, but of course, before we answer these challenges, it must be clear that before anything else, we'd like to achieve the following goals. We'd like to prevent transmission of the disease. We'd like no healthcare worker getting infected while providing essential services. And of course, we'd like to know that there's intelligent management of resources. So the initial step would be all elective endoscopies should be suspended. And we answer this challenge. Sorry. I'm going back. Okay. All elective endoscopies should be suspended. Screening endoscopies, staging endoscopies, combined endo-lab procedures, and even endoscopic ultrasound. And then, of course, before I give to you the guidelines to triaging emergent and urgent endoscopy, I'd like to share to you how we responded to this challenge. So I had to ready the team, the hospital, or the Department of Surgery with regards to knowing or telling everybody that there should be zero contamination. So we initially identified an incident. So we managed this as like a disaster, and we identified an incident commander, a deputy incident commander, an admin liaison officer, a logistics officer, and the deputy logistics officer. We identified every one of them. We discharged patients. We made the manpower or the residents go on skeletal force, meaning 4 members, a senior, a junior, and one going for the ER or the influenza-like tent, a runner who is actually our first year, who also doubles as our spotter or a buddy during PPE donning or doffing. And we had to sit down or sit out most of the residents who have comorbidities or who had high risk exposure. And we all went to disaster mode. We bought food, we bought water, we made sure power supply is ready, made sure that those who were sent out to the hospital have shelter or very near the hospital. We made sure everybody had clothing, and we made sure that everybody has a buddy who would check on them, just in case nobody would like to check on them or nobody can check on them. And of course, we established a rapid communication. We bought walkie-talkies. We made sure that Viber or the internet is okay. And we did daily pulse or check on everybody. Those who were sent home were checked by a buddy or checked by everybody or checked by somebody to make sure that they are okay. So we disseminated the plan, we took action, and we repeated this cycle or reiterated all the very things that are important during the planning. And we modify accordingly and update accordingly. Of course, there were, as mentioned earlier by Dr. Te, that there should be engineering controls and there were infrastructure changes in the hospital. I might have to say that our hospital is a government hospital and we have poor infrastructure and we have to change. And all of these things, from rapid communication, market management of the manpower, down to infrastructure changes, happen simultaneously, just like what we do in trauma assessment. Your ABCs is done alongside with the secondary evaluation. So after everything has got stable, then it was time for us to summarize and collate all information from all the relevant societies. Then we were able to produce or be able to guide ourselves or make a algorithm for endoscopy, emergent and urgent cases, so that we'll be able to triage them carefully. So this is the algorithm for it, and I'll break it down to you one by one. So if you have a patient for endoscopy, we segregated them for upper GI, biliary, and lower GI endoscopy. One thing we'd like to establish here is we'd like to know the COVID status of the patient. And there should be a COVID triage team, which the institution has, like an infectious disease team that would determine the COVID status of the patient. But of course, it's incumbent to you as a surgeon that you ask for the following: your FT or FOTCC, fever, history of fever, your occupation or the occupation of the patient, travel history, patient belonging to a cluster where an area wherein infection is very high, or the patient is part of a contact or part of the contact tracing of other infected patients. These are important things that you have to ask your patient, FOTCC, so that if it becomes positive or patient would have anything within the FOTCC, then you should stop first and determine COVID status. So what we did was we standardized internally in Rizal Medical or our PPE levels. levels 1 to 3. We based it on guidelines and experiences of the aforementioned staff who had experiences with the SARS. And basically, it was a stepped up level of PPE or an overkill because we wanted to protect our number one asset, the healthcare worker. Because mainly we had poor infrastructure. We had no negative pressure ORs or units. And of course, we want to manage our PPEs because we had a lot of donations, but we're not sure how reliable they are. And some of the donations were fake. And of course, there were delay in PPE supply coming from the Central Department of Health. And basically, we were all caught off guard. So this is an example of our levels of PPE, 1, 2, and 3. And level 1 would be the ones wherein we have a doctor or an MD or a healthcare worker seeing a non-PUI or the outpatient department. Level 2 would be those who are in the emergency room or there's a potential for person under investigation exposure. And then any procedure that's COVID positive is a highly enhanced level of PPE. Of course, we promote proper donning and doffing. And it's highly encouraged that there's a buddy or a spotter to assess PPE breach. Of course, we'd like to do that because the risk of infection for the healthcare personnel is around 29%. So I'll go down to the indications for upper GI endoscopy during these times. And the only indications that would warrant endoscopy would be variceal bleed, non-variceal bleed, caustic ingestion, and foreign body ingestion. And we can actually go for endoscopy straight for these patients. And then, of course, determining the COVID or non-COVID status. Even if the patient is a non-COVID, according to the triaging system, we do require them to wear a level 2 PPE. It is to protect them because we're not so sure about the asymptomatic carriers. And most of the time, COVID testing comes in 5 to 14 days later. It's too late. So even though the triaging group would classify the patient as non-COVID, we require our staff to wear a level 2 PPE. Of course, definitely if patient has a positive FOTCC history, so patient becomes a COVID suspect, COVID probable, or a COVID positive, or COVID confirmed, then we ask them to wear a level 3 PPE. As for malignant or non-malignant obstruction, perforation, or even post-op leaks needing stenting, Ovesco clamping, endoscopic internal drainage, it has to be thoroughly discussed with the team, anesthetic team, nursing team, surgical team, because there might be an alternative procedure to tackle the problem. And of course, everything will have to depend on the availability of technology and expertise. So we now go to the biliary. So the only biliary procedure or endoscopic biliary indication or the ERCP straight away is on severe cholangitis, Tokyo Guidelines 2018. And of course, once a patient is severe cholangitis, we go straight for ERCP. Now, malignant obstruction with regards to biliary will have to depend on the availability of expertise and technology. Of course, as mentioned, we cannot overemphasize the level of PPEs that we want our endoscopists to wear. And another track for the biliary would be those who have high risk for stones or who are in moderate cholangitis. So as much as possible, we'd like to veer away for with endoscopy because this patient, the procedure itself will generate aerosols. So we'd like to know if there are any other procedure that is available aside from endoscopy, like interventional radiology, which is PTBD or surgical treatment. And if yes, then we all proceed to do the alternative procedure. If none, then we go for endoscopy. As mentioned, PPEs are important. And if there's a failure of the alternative procedure, then we go for endoscopy. For lower GI, bleeding and obstruction, left-sided or volvulus, if there's any other procedure, then aside from endoscopy, we try to go for that. We proceed for an alternative procedure. If it's not available, then we go for endoscopy. If there's failure of that alternative procedure or it's not available, then we go for endoscopy. So basically, that's the way we do or triage or endoscopy according to urgent or emergent cases. And I'd just like to show you our experience with that algorithm that we used. So first week of the lockdown, we had to ready the team. We had to make sure that everybody has to know that we should aim for zero contamination. So we oriented everybody inside the department. We made sure that everybody is identified because we all know that we'll be wearing masks, goggles, and all those PPE, and everybody would be difficult to identify. We had to call in everybody, made the resident roster, or made sure that the residents get rested. So we went on skeletal duty or skeletal force. So the interval of duty would come in from every 5 to every 6 days, meaning the lesser number of duties, the lesser number of chances being exposed. We had to sit down most of the residents who had comorbidities like asthma, DM, and other immunocompromised states. We had to discharge most of the patients. We bought in groceries. And of course, we want to make sure that they take their daily dose of multivitamins. And then we established rapid communication by our walkie-talkies and made sure that we have connection with other members of the department. Like there's a core group wherein we called it covert ops. Then there's a group, residents and fellows, wherein we check or poll them every day if they're okay. And then there's a consultant group wherein we check them and tell them who's on duty. And of course, before we start the day, we do our daily prayers. And then initially we had these improvised PPEs or the raincoats. We knew that this was not okay, so we bought our own PPEs initially. And we knew that those braceries or these bras will never work. And then after that, when everything was stable, we were able to put into action and able to collect everything and made this algorithm for endoscopy and even in surgery, which we use internally in the department. So I'd like to show you, these were the first few weeks. We did an ERCP on a patient wearing the PPEs that was available or were available. We were wearing goggles and 95 mask, double layers, double gloving. And if you can check on the other side, it was very difficult to do the procedure. I can't even see everything. There was, the goggles were fogging and the procedure is very difficult to do. So I had to issue a statement wherein the most expedient and most efficient way to save the patient or tide over the patient has to be done. But of course, as we repeat through the action, we were able to modify and then slowly stabilize. And we were able to establish, aside from rapid communication, teleconferencing already amongst the residents. And it was the head and neck service who did the first teleconferencing. And then we were able to push out some patients from the ICU, transfer them somewhere, and then converted it to a COVID OR. So we had to segregate them. So the ICU was turned into a COVID OR. And if you see, as we modified everything, we were able to stabilize also on PPEs, induction, which part of the hospital is segregated away from the normal hospital operation. So we had a COVID OR already identified. And we were able to do some modifications wherein donning and doffing areas. So we were able to do some sequence beans and sequence tables because it's very difficult to memorize the donning and doffing sequencing. And then, of course, the goggles were difficult, so we had to purchase this full face mask. And if you see, the only problem with this situation is we all felt lightheaded. It was, it was tiring inside. It's so hot. It's so warm. And of course, after doing the case, oh my God, there's another case to follow. So we modified everything. We bought this full face mask from booties to boots, and then we made sure that um, the healthcare worker is protected. We tried to innovate, meaning try to place oxygen over the area where the filter is, and then but this is all anecdotal, but we made sure we tried to see if our O2 sats were actually really going down. So if I don't have the O2, it's 95. If I have the O2, it's 97. So urgent and emergency endoscopy were the ones only done during the lockdown period. Infrastructure has to change if possible. Endoscopy room should be on negative pressure. If it's not available, we do an alternative, or we make alternatives. We keep the area ventilated and make sure air does not go recirculated. We prepare the equipment. We do proper disinfection of equipment after the procedure. And then we segregate patients according to protocol or guidelines by the infectious disease service. So the most important lesson that we were able to learn here is to protect the staff, because we want them to have the proper attitude that this is something that's difficult to defeat, and we have to know the enemy. We have to orient them with proper PPE use, because bottom line, they're the most important asset in this pandemic. So everything is very fluid. We were very open to modifications on a day-to-day basis, as of course there's no expert on this pandemic, and we all have to pull our experiences to deliver excellent, efficient, expedient, and safe surgical care as much as possible, and we want zero casualty. So this is my team. I have a deputy commander. I have a shopper or a logistics officer. I have a liaison officer. And of course, I had help from the whole Department of Surgery. And with that, I'd like to thank you for your time listening to this lecture.
Okay, thank you, Dr. Ray Sarmiento. The questions will be entertained after the last speaker. Our next speaker is Dr. Miguel Mendoza.
Okay, good evening, everyone. Can you see my slides? Yes?
Yes,
Yes,
I.
yes.
All right, good evening, everyone. And first and foremost, thank you to PAHPBS as well as to PALES for the kind invitation. Congratulations to our two previous speakers for an excellent presentation. My presentation will be more of a summary and some emphasizing on the certain points that they mentioned. Good morning, Horacio. Thank you for being with us, and good evening to all the our participants out there. The topic I will have to present today would be the operating room environment during the COVID-19 pandemic. And this is a very important topic in order to consolidate everything that we have learned as we went along, and share with you these factors that we have contributed in our own hospitals. The way we do surgery today seems to be different in several aspects compared to the way we used to do surgery prior to the COVID-19 pandemic. I think this is very true for everybody, for every surgeon who has been to the operating room. There are new realizations. We pay more attention now to details of the OR. We now know that smoke plume is a concern. We understand the value of smoke evacuators and air filters in the operating room, which we used to ignore in the past. We are now more conscious about room pressures in the operating room, positive pressure, negative pressure, neutral pressures, which really we did not think about when we did our surgeries in the past. PPE is a must, and donning and doffing is something that we had to learn to do very well at these times. Airflow is a concern in the operating room. We know that aerosols do exist and they can be deadly. And we are now more conscious than ever of the safety of every healthcare worker. Our behavior now, probably this is the best realization I've learned, is that our behavior in the operating room may affect the safety of others. And the behavior of others may affect our own safety as well. So the current environment now, as far as the operating room is concerned, is focused primarily to protect the healthcare workers from the risk of exposure to the SARS-CoV-2 virus. And what is the current OR environment as a result of this? Well, the current OR environment was and is influenced by more knowledge of the behavior of the novel SARS-CoV-2 virus and its deadly effect. It is changing as we went. It was changing as we went along. The current OR environment is also as a result of the position statements and recommendations from various international and local surgical societies. As a result, directives in line with these positions and recommendations from the Hospital Management and Infection Prevention Control Committee was cascaded down to the surgeon. This resulted in the development of new OR protocols, deliberate understanding of and compliance to the standard and transmission-based precautions, as well as the purchase of necessary new OR equipment, instruments, and PPEs, and also the development of new innovations as a necessity to our work. The Philippine Association of Laparoscopic and Endoscopic Surgeons came out with this infographic and the position statement and recommendations that was distributed to the entire country to our fellows. My speech will cover on the PPEs, the tips on MIS, anesthesia and induction, and the smoke evacuators and filters. The society has recommended at the very beginning that emergent and urgent procedures are the only procedures to be allowed. So what we see now in the operating room are all emergency cases. Cancel or postpone all elective procedures. And the main reason for this, which was difficult to understand by some in the past, was that to mitigate the risk of exposure and transmission of the disease to the healthcare worker and to the patient. Another reason is to conserve manpower, which we used in the operating room or in the front lines. And also conserve PPEs, which may also be used in the operating room and in the front lines. We were also advised that when in doubt, we have to treat all patients as if they were COVID suspects or COVID confirmed patients. Patients may be asymptomatic. They may shed the virus even before they develop the symptoms. So it was a difficult world out there, and also more difficult as well in the operating room as surgeons. We recommended as well in the PALES, it's ideal to have two separate teams, a COVID team and a non-COVID team. And these are the people who are separated based on the function that they will perform these surgeries on these certain people, in order to conserve manpower and also to prevent cross-contamination. This was good from the entire surgical team. However, this was not always feasible in the operating room. Therefore, it is emphasized, as what was emphasized by two previous speakers, is to use the appropriate PPE. And in COVID confirmed or probable patients, the enhanced PPE is recommended. Ensure a strict, proper and donning and doffing sequence with a spotter together with you. And there should be strict compliance to the now known standard and transmission-based precautions. The workflow, as mentioned earlier in the operating room, has also been changed. We have to organize the workflow in tune with the times and simulate this workflow to eliminate the risk for the team for providing care for the patient. And it has been emphasized, triaging is very important. The transport from the floors, from the ER, from the ICU should be already established. Clear the area, and a dedicated elevator to the COVID room has to be established. proper and safe endorsements by the nurses, minimize the number of people in the operating room, prevent entry and exit, assign a runner, trolley cart, prepare all the equipment, request for materials over the phone instead of what we used to do as face-to-face, practice intubation techniques to be performed by the most skillful of the anesthesiologists. Surgical team stays outside the operating room until the time that the intubation is done in order to mitigate the risk of exposure and transmission. Emphasis was done on donning and doffing. Watch the videos, practice repeatedly, have an observer present, designate a cold zone, designate a cold zone for the donning and a hot zone for the doffing, perform hand hygiene. These were the constant reminders in the operating room, not only to the surgeons, but to our nurses as well. We have to be knowledgeable about the kind of PPE that we will need depending on the patient. And the most important here would be the enhanced PPE when you are dealing with a COVID-confirmed patient. We also recommended in PALES some recommendations on the minimally invasive surgery technique, like do not reuse disposable trocars, make appropriate size incisions, minimize change of instruments, cautery to the electrosurgery to the minimum, and use suction liberally, among many other recommendations as a result of what we have learned from others in various countries and various societies. And we also emphasize that we apply laparoscopy only in selected cases where COVID-19 is absolutely ruled out, and in selected patients where the benefit of the procedure significantly outweighs the risk of potential contamination of our healthcare worker. It is imperative that pneumoperitoneum evacuation and surgical smoke from a filter be done, because the premise is that safety of the entire surgical team in the operating room at this time should not be compromised or even in the future. We now pay particular attention to anesthesia and induction precautions. The anesthesia machine, at least in our OR, are covered with clear plastic drapes to minimize the contamination of the machine. A HEPA filter is placed between the patient and the breathing circuit to prevent contamination of the machine. An HME filter is also placed to prevent in the expiratory tube to prevent the contamination of the environment. And these are changed regularly after each and every case. Aerosol boxes, as mentioned earlier, is a common sight now in the operating room, unlike before. Vigilant laryngoscopy is the preferred technique by our anesthesiologists. And again, the surgical team stays outside of the operating room until the intubation is done to mitigate the risk of exposure to our healthcare workers. It has been also recommended that to separate a COVID room from the non-COVID areas where we perform our emergency surgeries for non-COVID patients. And therefore, if it is feasible, then put that COVID room in a separate tower or a separate building if our hospital has that. In a negative pressure room, in a negative pressure ante-room, designated cold and hot zones in those areas. However, if this is not feasible, the recommendation is to place that operating room in the farthest area of your OR complex in order to prevent cross-contamination. In our institution, we would also see these signs labeled as whether the room is negative pressure or positive pressure, because most operating rooms, as we know, are positive pressure rooms. And therefore, in our institution, we designated the COVID room in the endoscopy complex, where some of the rooms are already at negative pressure. And we just converted this into our COVID room. And as you can see in the floor plan in our operating room, we would see a dedicated elevator where the patient passes through, enters the hallway of the endoscopy complex, and goes directly to the negative ante-room and also the negative pressure COVID room. This is the blue arrows that you can see over here. For the red arrows, that is the path of the surgeon or the team and the nurses, where they will enter into this complex separate from the entry of the patients, and they will do their donning in this dressing area, which is the safe, and which is a cold zone. When we or choose a COVID room, it is best to perform these surgeries in a negative pressure room. This is the ideal, if also to have a negative pressure ante-room. The main reason for this is to understand the basic concept of pressure when it keeps the viral pathogens within the operating room, and the airflow is filtered out into the environment. Most OR are positive pressures, and therefore we have to closely coordinate with the engineering team of the hospital in how to mitigate the risk of the disease into the hall. We have to take into consideration important aspects like the air change per hour. Recommendations for the air change per hour is around 12 to 15 air changes per hour. And before we not think about this, but now because of all these things, in order to mitigate the risk of transmission to our healthcare workers, we have to understand all of this in the operating room. We also have to understand that laminar flow is also important because it facilitates contaminated air from the ceiling down into the exhaust grills. Streamlined flow of contaminated air from the ceiling goes down into the filter ductal system into the environment and eliminates turbulent flow, which may cause, again, transmission of the disease. Cleaning and disinfection in the OR environment is also very important. Terminal cleaning, it should be done after each and every case. And sometimes there are recommendations to do room disinfection for UV irradiation, ozone mist, or hydrogen peroxide vaporization. But there is yet no solid recommendation coming from the CDC regarding this. But nevertheless, if it is done, then that would probably be helpful as well until new evidence comes in. The key is to be able to protect our healthcare workers. Proper air filtration isn't a luxury anymore in healthcare facilities. We realize that it is definitely a necessity. And that's why we're now exposed and know more about HEPA filters, ULPA filters as we do our surgeries in the operating room. HEPA filters now, we're more aware, they're 99.97% efficient for 0.3 microns organisms, as well as ULPA filters with a higher efficiency of 99.99% for 0.05. And we know that the SARS-CoV-2 virus nowadays, the size has been placed at 0.06 to 0.14 microns, which essentially is covered by your ULPA filters. As a result, SAGES and EAS also made recommendations regarding the use of filters during laparoscopic surgery. It says all the previous research has shown that laparoscopy can lead to aerosolization. There's really no direct evidence to it, but there's also no direct evidence as far that it is not present in the aerosols. So we would rather err on the side of safety of our healthcare workers, and these are recommended. Smoke filters, as well as smoke evacuators, as recommended by the American College of Surgeons. There are a lot of smoke evacuators there out there by our industry partners, and these are the smoke evacuators that we have gathered, at least from the SAGES website, and this is what we have. Some of these we have in the country, and also we have the passive smoke evacuators that can be used for laparoscopic surgery. Dr. Catherine Te mentioned about the innovation, the closed filtered suction system for innovation. You have seen this in her slides. I'm just presenting this again as an emphasis for this. And also, Dr. Salud has showed me some photos as far as the HME filter that they use in a one-way chest tube bottle that is we are most familiar with, and using a HME filter connected to the trocar, eliminating the smoke. So this is, I think, a very good innovation and something that we want to consider in our institutions now that we are aware of the new normal. So in summary, ladies and gentlemen, the OR environment during the COVID-19 pandemic, we have realized the value of negative pressure ORs and negative pressure anterooms in order to protect our healthcare workers. Laminar flow with HEPA filters in the OR is a necessity as well. Smoke evacuators and ULPA filters are now part of our surgical armamentarium. Proper donning and doffing now should be strictly practiced and practiced and practiced. Enhanced decontamination and disinfection should be followed. Education in standard and transmission-based protocols should be understood. And all this, everything that we've learned for the past several weeks, may be the new normal in the OR environment in the future. But the most important realization is this: our behavior in the operating room may affect the safety of others, and the behavior of others may affect our own personal safety as well. Again, good evening and thank you very much for your kind attention.
Thank you, Dr. Mendoza. We now go to the open forum. To Professor Asbun, can you give us your opinion on this impact of COVID-19 on innovations in planning and surgery? And also, there's a question, do we still need to wait for the curve to flatten before resuming the elective surgeries? Dr. Asbun?
Thank you, I appreciate it. First of all, congratulations to all the speakers. It is incredible how, again, this crisis has made us all join forces and interact the same way that your two societies today, PALES, as well as the HPB, Filipino Association of Surgery of HPB, have joined forces. The lectures have been excellent. I mean, from Dr. Chua, who clearly showed how being on the front lines is not something that's easy to do. I just want to emphasize what she said. She clearly stated that going to do surgery, you now fear for your own safety. And as Dr. Te said, do you take these risks to your family members? Dr. Chua said it very casually, but I just want to emphasize it's okay to be a fear. It's okay to be scared. It's normal. It's a normal feeling. And courage and fear are not exclusive of each other, right? And that's what I was saying before on a SAGES communication. The fact that you're fearful, you need to honor that feeling. We all have it, and we shouldn't run away. But that doesn't mean that we don't have courage. On the contrary, if we still go and do what we have to do as physicians and surgeons, that shows we have courage. Then both are feelings that we need to acknowledge and that we need to feel proud, particularly the courage of us continue doing what we're doing. In regards to Dr. Te's presentation, as well as Dr. Mendoza, it's pretty impressive how ingenious you all are doing several things. And I think we all are trying to learn that. I would like to ask both of them in a moment. It seems that you have planned and organized everything very well. Having said that, you do have a high mortality among your healthcare providers. And from all the participation on the different webinars, I see you in the Philippines, at least in the way how you have exposed it, you are well prepared. Then I'm gonna, once I finish my questions, if you don't mind, I'll ask you to answer that. Also, Dr. Mendoza, you and I should probably talk a little bit more about laparoscopy. We have a little different perspective. You were saying in your lecture that we should avoid laparoscopy as much as possible. We have done a lot of research with the SAGES group, and we're not sure that really what is the risk of laparoscopy. And in fact, I'm not saying that it's better than open, but also there is people that proposes that in laparoscopy, at least you can control the environment. If you do a closed circuit and eradicate all the gas in and out, and as you said very well, do the small size incision, you put the trocar well, you don't let it, you don't do instrument exchanges, all of those tips that you gave. Plus, if you use a filtration system and when you evacuate the pneumoperitoneum, that nothing goes to the air, you use the lower pressure possible, then at least we're controlling the environment. People feels that in an open surgery, particularly if you're going to transect the bowel and so on, it's much more difficult to control the environment. And as Dr. Te showed on her lecture, there is a significant amount of patients where PCR has been cultured from the intestinal tract. Then I need to be clear. I'm not saying laparoscopy is better than open. I'm just saying we're all afraid of laparoscopy, but in reality, there's no science, and it may be even safer because we control the environment. Dr. Sarmiento, I think again, I would like to hear your opinion on the, you mentioned several times about the SARS experience. One of your team apparently worked in SARS. We here in the United States, the majority of us never had any experience with SARS in the operating room or treating patients. Then I would like to know how that has influenced your approach into this. I mean, did you have to do all of this in SARS or not? Then those are more or less my questions. I'm honored to be on this panel. It is certain that it's pretty clear that the panelists are now experts on this. Many times in countries, I mean, I come from South America. Many times we see groups like us here in the United States now as, oh, they know so much. Well, guess what? You have to be very proud about the research you have done, the measures that you have taken, and how you are implementing it as illustrated by these lectures. Thank you very much.
Thank you. Ray, you want to react?
Yes, thank you for that question, Dr. Asbun. And with regards to the SARS experience, the only thing that the two members of the team was able to relay to me, or the most important thing that they relayed to me, was if the infrastructure or the engineering cannot be changed, the culture is difficult to change, then it is mandatory, or it is but must proper to protect the healthcare worker or the person who's going to attend to the patient. Because bottom line is, if we don't have the healthcare worker, then we won't be able to treat these patients coming in with infection or with this viral infection. So
Thank you, Ray.
that became my priority. I wanted to protect my staff. We don't have the PPEs. It came in late. We had to buy those masks. We had N95 masks. We are not sure about their quality or their origins. Some of them came from China. I'm not sure if they're fake or not, but I just wanted to make sure that my staff is protected. So I asked them, do not wear those masks. It's either you layer them, or the department purchased this 3M half face mask to make sure that we are using the proper masks intended to protect our staff.
Thank you. Thank you very much.
Thank you, Ray. We also have here a GI, Dr. Carlo Lazaro. Would you like to give your comments?
Yes, Dr. Ong, thank you very much for giving me this opportunity, and congratulations for a very good, comprehensive webinar. It doesn't fall far from your recommendations, and the Philippine Society of Digestive Endoscopy has released the latest guidelines last week. I can direct you to the PSDE website. Just a few, I agree that we have to fight for, and we have to really work for testing our patients, because the guidelines in the Asia Pacific and even abroad advocates testing all patients. Only then you can really place your patients into COVID positive or COVID negative. If we cannot test our patients, we know now, because there's a huge community transmission now, then I agree that we have to treat all patients as infected. Therefore, we have to equip our staff with adequate PPEs. In fact, in PSDE, we are advocating no PPEs, no procedures for the patients. We agree that we have to limit all procedures to urgent and emergency for now. And the list, we just added those patients with an obvious tumor. For example, in CT scan, you see an obvious tumor, it's in the stomach, or it's in the rectum, then I think it can be considered as an urgent procedure, and you can wear the proper PPEs and do that procedure. Now for semi-urgent, we recommend, like you, to hold this until our numbers are down, until we know what really the curve is, and until we can do massive testing, and until our staff are ready and our hospitals are ready. Like Dr. Sarmiento said, we cannot be suffering from another curve. So I think that it's basically the same, but we have to have proper PPEs, and we have to limit our procedures. For procedures, we limited our team to the most essential teams, and we put in a team that is good in ERCP, good in upper GI, so that it will have a minimal exposure to the virus and minimal transmission.
Thank you, Dr. Lazaro. Dr. Maki Felona, you have the floor.
Just a comment on the use of the face masks of 3M. Of course, the filter cartridge of the 3M is not enough. You have to add the 5N11 and 95 filter to the filters. And one thing that you have to remember as well is that these filter masks have an exhaust valve. And if you are a COVID asymptomatic, you have to cover that exhaust face valve with some form of filter so that you might lessen your possible infection of your co-workers if you are asymptomatic and you don't know it yet. So that's the other thing that you have to remember. All of these face masks, they do have expiration valves, which you might actually put out aerosolized droplets, and you have to have something covering that. Others would advocate just putting a surgical mask on top of the face mask so that you cannot contaminate your coworkers, just in case you are a COVID asymptomatic individual.
Okay. Thank you, Maki. Dr. Mendoza, you have something to say?
Yes, I would like to thank Horacio for your question. I think that's really very important. During the early part of the COVID-19 crisis, we really didn't know anything about the virus and how it would be transmitted and all these things. And recommendations coming from societies would say that to choose very well which procedures are for laparoscopy or not, and the benefits shall outweigh the risk. I totally agree with you, Horacio, that probably laparoscopy would be a good option for these patients because the environment is controlled, provided that we can control the environment. And there are some certain precautionary measures like what you mentioned in terms of the technique that should be emphasized to our surgeons, as well as the filters and evacuators that should be present. With this present, then a lot of surgeons would like to go back into the laparoscopic procedures as soon as they could, because of course the most important, as we all know, is to protect everyone. Although there's no direct evidence to it, we just want to make sure that all the necessary precautions in the control of the environment will be done. I totally agree with you. Thank you.
Thank you, Ike. Dr. Domino?
Yeah, good evening and good morning there, Professor Asbun. I do have a question with regards to laparoscopy. Have you started to do or go back to practicing again elective laparoscopy in your center?
Thank you. And again, thanks for reminding us of that. Dr. Ong had kindly posed that question, and we kept talking and we forgot to answer it. Then the question before went in line, are we ready to start back? I think the answer is very dependent on where are you. We form an international global collaborative group that we meet every Friday. In fact, I'm going to be meeting now pretty soon. And we have seen how Italy, Spain, Netherlands have started to plateau, and now they're talking about reopening. Here in the United States, we're not there yet. Even though Florida apparently has been hit a little less than what it was predicted. And I'm not saying that it's a small amount. We had over 23,000 cases. Then it's a significant amount. My hospital got at some point 135 cases and around 35 ICU patients. Now we're on the 60s and 70s and around 27 ICU patients. Then we're not ready here to start. However, there are other areas that are starting. Last night, we had a webinar with SAGES speaking only about that. When is time to go back? And we had participation from the president of the European Association of Endoscopic Surgery, another Italian surgeon, etc. Then the webinar is going to be posted at the SAGES site probably within the next 24 hours. And during that, the sum up is that we cannot give a general rule to everybody. we need to make sure that each area, each institution does their own decision-making process. Having said that, everybody agreed that the same things that you're saying. What is going to be the new normal? The new normal is not going to be jump in and do everything like before. We will have to screen patients. We will have to screen people from industry that are coming in and out. Are we going to have observers? I'm very fortunate. I had several observers from different parts of the world. I mean, in fact, I have had observers from the Philippines before, and it's a pleasure to have, and these are many times residents that have an elective rotation or surgeons. Then are we going to continue having those observers? I would hope so. But now those observers are going to have to be, tested before coming into the OR. And then, yes, we all have to be thinking about going back. We personally are not back doing elective surgery right now, but we are planning to start doing that probably within the next 2 to 3 weeks, but we'll ease back into it, starting by, we're dividing the cases by priority. And of course, we all know the cancer patients, etc., and start going back towards more elective cases, but cautiously, and assessing if this is going to come back or not.
Thank you, Dr. Asbun. Alan? Dr. Benefe?
Hi, good morning, Horacio.
Good morning, Alan. And I'm sorry, I forgot to mention that ELSA, which Alan is, a past president, is a participant of our global collaborative every Friday. Then it is a pleasure to have you with us.
Thank you. I just don't know the time of the meeting today. Anyway, I agree actually with Horacio. There's a lot of protocols, a lot of guidelines that came out post-COVID era from CJS, from AES, even from our local society, the PCS. Just this morning, our department from Batangas, it's a government referral hospital south of Manila. We have a meeting this morning, and we were talking about following the guidelines of PCS, the PCS of guidelines, in as much as we have our own society guidelines. It's actually based on a lot of international protocols and guidelines. And I would say that if you're that the number of COVID patients coming down at least in 2 weeks' time, you can consider opening up for elective surgeries. But then again, just like what Horacio said earlier, it has to really depend on each institution or each hospital where you are practicing. For example, even in the Philippines, a lot of hospitals in Metro Manila, if you look on their system, on how the surgery or how the patients are being, the separation of patients are quite different from the other hospitals, especially the government hospitals in the provinces. I think the gist of any guidelines would always look for the safety not only of your patient. Of course, we would want to ensure success of your surgery on patients, but nowadays, because of this pandemic, we'd always think of the safety also of the healthcare workers and especially the surgical team. And I really agree with Horacio with that.
Thank you, Alan. Yeah.
Thank you, Horacio, for joining us and giving a lecture to us. Very nice lecture. Thank you.
My pleasure. Thank you for the invitation.
Thank you. Dr. Tan? Dr. Ernesto Tan, please. Alvin, please unmute Dr. Tan.
I enjoyed the lecture.
Already unmuted.
Yeah, I enjoyed the lecture. I have no more questions.
Okay, thank you, sir. Dr. Ate, Catherine?
Thank you, everyone, for your wonderful talks. I just thought there were a couple of questions that I would like to air it live. The There was a question that was asked about surgeon refusing surgery if there is no available PPE. So what are your thoughts on that? Can a surgeon refuse surgery without availability of PPE?
Is that on a patient with COVID or suspected to have COVID, or is that on a patient that it is normal?
There is no mention about it, but it's a question that was posed by one of the attendees. So let's just say that it is a suspect. It is not confirmed. Let's say it's a suspect.
Since there is not, let's just go back to all the patients. Despite that I live in the United States, and supposedly we have a lot of resources, today I'm doing surgery on a patient that is not COVID or suspected. I do not have any personal protective equipment other than the normal surgical equipment. And in fact, they give me one regular surgical mask per day. And that is because we're keeping all the N95s and everything else for the future. Now, ideally, that's not ideal. Ideally, we will all have N95s, particularly now that are being re-sterilized and so on. But the reality is that not everybody, and I assume in countries like the Philippines too, not everybody is going to be able to do surgeries with with N95s for all patients. Then I would say a surgeon, if it is operating on someone that is not suspected of PPE, or suspected of COVID, should do the surgery as long as it has the regular, gloves and a mask and normal stuff. Now, if you're doing in somebody that's suspected, or in somebody that it is COVID positive, and you don't have the PPE, and as PPE, we're going to state N95s and the really high protection. Are you going to refuse surgery? I think as surgeons start talking about, am I going to refuse surgery, doesn't really speaks at the spirit that a surgeon should have, right? We're going to assume, because the details are not on the question, we're going to assume this is a patient that really needs the surgery, right? Because if it is a patient that's COVID and you have kind of an elective thing, or he has appendicitis and you should try out antibiotics, you should try to avoid surgery. But let's assume, Dr. Ted, that you're asking me, this patient really needs surgery and is COVID. And guess what? You don't have PPEs. And as a PPE, I mean, significant protection. Well, that is a difficult situation. And I don't have an answer to that, because we all are going to have to decide that. My first choice would be, if there's no PPE for me, there's not going to be PPE for my team, I'm not going to want to risk my team. It's not just about me. But then we're talking a little different, right? We're not saying I'm going to refuse doing surgery. That's not the attitude. The attitude is, well, let's put things in a consideration. And then that attitude is going to allow me to see, can I do something else? Can I go and look for PPE from a different hospital? Is somebody has here they are sterilizing the wrapping paper of the instruments boxes, and that apparently filters like N95s. Then you need to try to have an attitude of, let's solve the problem. Now, if at the end of all my efforts, I cannot find PPE, then I don't want to expose my anesthesiologist, my nurses, my OR team, and myself for one patient. And unfortunately, we would have to make a tough decision there. Hopefully, I will never get to that decision. But again, I emphasize the attitude should be different than saying I'm refusing to do it.
Absolutely. That's a very good question, answer to that. And then really, it is not just a matter of answering whether you will do the surgery or not, but you need to take care of your team. And as I mentioned in the talk as well, we need to, one of the important things is to look for alternative solutions. And in every case, there will be alternative solutions unless there is no other solution. You really have to be put in a very difficult position. Talking
let me add one more concept that may help. That when we have a pandemic, normally in our daily lives, let me say that the focus of a surgeon is priority to take care of the patient, one patient. When we're in a pandemic, is take care of the society. Then yes, the patient is part of the society, but my decision-making process is more towards protecting the group, protecting the team, rather than a single patient.
Right, absolutely. You asked about the reason why we have a high mortality rate amongst healthcare workers, and I was not answered, despite being prepared. It appears that all of us have been preparing and planning, and we've shown you that we have reorganized, restructured, and have workflows redesigned to suit this need. I think the reason why we had a fair bit of mortality in the healthcare workers were in the beginning when they were not aware yet, and there were no PPE, not enough PPE at that time. So the awareness and the lack of PPE and probably the culture where we think it is not as serious was where one of the reasons, because the mortalities really were in the beginning of the surge. So that's the reason. Now regarding lab versus open that you asked earlier, I totally agree. In the beginning, definitely it was fair because we know for a fact that there is a lot of air leak a lot of times, especially for some, particularly some specialties. For example, in HPB, we do extracorporeal Pringle maneuver. So that I have included in our recommendations for those who do laparoscopic hepatectomies. We should try not to do extracorporeal Pringle. Instead, we do an intracorporeal Pringle. And we don't want to suspend your organs outside as well, because for example, when we do pancreatic surgeries and we suspend the stomach, insert a Carter Thompson and pull it out on sling. So these are all potential air leak procedures. And of course, putting in a sponge, we like putting in sponges when there's bleeding, and these cause air leak, gas leak at that during those times. So I think, in fact, it is not about doing laparoscopic or not, but really being very careful, being more cautious and more meticulous in the technique and in the process of doing laparoscopy. And things that we have never been worried about before, like the smoke evacuation systems, we never really thought about those things. But because of this, I think COVID-19 has become a catalyst where all of us have been thinking of various ways, because it means something. It affects us and it affects others too, just like what Dr. Mendoza has mentioned. There were many questions earlier also from the panelists about what are the criteria, and I think I have summarized it comprehensively in the 10 P's, all the P's that I have mentioned. If you are able to fulfill all the criteria, then I think we would be ready to resume surgery, taking into consideration the availability of our resources. I think one of the things that is really stopping us is the test, the reliability of the tests and the availability of the tests, knowing which or what kind of patient you are facing or doing surgery on, and the availability of PPEs, availability of blood. Blood is now very scarce. So it's very hard because without the blood, without intensive care, without the equipments, instruments that we need, it's very difficult to go through a surgery without those things at hand. So I think apart from prioritization of whether the patient has cancer or not, and whether the cancer is rapidly growing, we need to take into consideration the availability and the tests that we can do to know the status of the patient, we have to take into consideration that a lot of these patients don't disclose everything. And we may not know that they have been in contact with someone. And a lot of them also are asymptomatic. In a couple of the papers that Wuhan has published, significantly, many of the patients were asymptomatic and negative in their PCR, but showed subtle changes in their CT scan. So we really have to fight for it to do a CT scan for our patient prior to surgery, because this is the opposite of what infectious and radiologists are saying. Chest x-ray is good enough, but there are cases where chest x-ray don't pick up these subtle changes. So I think we need to fight for these things, because it not only implies on the safety of the health workers and ourselves, but also on the prognosis of the patient post-operatively. And these are deaths that can be prevented.
Okay, Kathy, thank you. We're running out of time. Juby?
Thank you. I apologize. Unfortunately, I'm going to have to leave to join another conference. I want to thank again the organizers for this invitation, and congratulations to all the speakers. This has been very educative, and again, thanks to Philippines for honoring me with the invitation.
Thank you, Professor. Thank you, Professor. Juby?
Thank you, Professor. I would just, I would like to ask, I think most of you are leaders in your own institution. I think the test was mentioned earlier. If we are back in our new normal, how would you position testing maybe in your algorithm with regards to surgery, with regards to your patients and the healthcare worker or the surgeon for that matter? And also maybe my second question would be, how will this affect surgical training in our country?
Ray, you have the mic.
Sorry. Okay, question with regards to testing. Tama ba ako? Iintindi ko. It's,
yes.
With regards to testing.
Yeah, kasi pag new norm na, ano kayang testing na ilalagay natin sa algorithm? If it's already available, are we going to test our patients, our staff? How would we position this in our algorithm for our COVID and non-COVID patients?
I think first we have to consider the sensitivity of the test or specificity of that test. Tapos yung rapidity of that test. May PCR test kasi na comes back 14 days after. Tapos na. Everything is done. But there are PCR tests that comes in within 15 minutes to 2 hours. Then that will be very helpful. Because you'll be able to classify your patient from COVID to non-COVID patient. Of course, your healthcare worker, you have to protect them, and you have to protect the patient from your healthcare worker also. So you have to test these healthcare workers. Antibody testing will be very helpful, of course, depending on the sensitivity and specificity of this test. But I think bottom line is, without these rapid testings or without these results coming in within the hour, other tests might be very helpful. Go back to your patient, take the history, the FOTCC, fever, occupation, travel history. Is he part of a cluster? Is he part of a contact tracing cluster? Then respiratory symptoms of your patient. And then I think there's a mention within the chat room or within the question and answer portion. CT scan might be very, very helpful, because CT scan might pick up chest findings earlier than serologic testing. Just like in radiology, what we call radiologic lag, di ba? May pneumonia na siya pero wala siyang chest x-ray findings. Baka dito baliktad. Meron na siyang chest x-ray findings, and then the serology or the testing comes in later, or other tests comes in later. Kasi of course we have to make sure that the test that we're going to use is very sensitive and very specific also.
Thank you, Ray. Dr. Bobby Bandolon, you have the mic.
Yes, thank you. Good evening, everyone, and thank you sa lahat ng speakers. Just wanted to address this question sana, and I was hoping to get the opinion of Dr. Asbun. Unfortunately, he had to leave, so I guess it's up to the speakers na lang, the rest of the panelists. I'll make this very quick. Do you have any recommendations or any advice with regards to laparoscopic colorectal surgery? See, anything specific for colorectal procedures? Mainly siguro kasi ngayon ang niisip natin yung mga lap-cole. So do you have anything that's quite specific for laparoscopic colorectal procedures? Thank you, and good job, everyone.
Kuya Ike, you like to answer the question? Anybody? The panelists?
I think I'm sorry. Yes, I think the question of Bobby is very significant. In any particular detail, I do not have, but those that I've mentioned in general is applicable to all laparoscopic procedures, at least the basic fundamentals of being safe as far as laparoscopy is concerned. So those things that were mentioned is applicable to all laparoscopic procedures as the fundamental basis to create that culture of safety inside the operating room during these times. Now, for specifics, maybe especially with the extraction of the specimen, that I would say that one has to evacuate all pneumoperitoneum first through that filter or through that device, the smoke evacuator, the smoke filter. Evacuate all of these, make sure the abdomen is collapsed, make sure there's no more pneumoperitoneum there before the extraction is done in that particular situation. That's probably one of the tips that I can give as far as that is concerned. Maybe others have more suggestions as well.
Kathy? Yes, Kathy?
Yeah, so in regards to Bobby's question, another thing apart from the precautions that and the tips that Ike has mentioned is that there are several recommendations that says do not open the specimen. It's because of the presence of the virus in the stool. So that's in regards to colorectal parts. So whether it's open or laparoscopy, so the recommendation is try not to open the specimen at this time inside the operating room. And then another thing is in relation to colon as well, is acute abdomen. We do see patients with acute signs of acute abdomen, but not necessarily really positive, because there are several things to keep in mind. One is that there is a possibility of having a false positive dengue test in this case. The ACE2 receptors are high in colon, in the GI tract, especially in the ileum and in bile. And that's the reason why we see liver injury. And these are very, very high, as much as 59% in cholangiocytes. So doing cholecystectomy, biliary surgery, ERCP, this is also high-risk procedure. The other thing also is that we may think that these patients have acute abdomen, but they're actually not, mainly because it's an effect of the virus in the GI tract. So those are some things that perhaps we need to be more cautious in terms of definitely labeling the patient as acute abdomen and going in to operate. Similarly, there are cases that were reported as mesenteric ischemia in patients with COVID positive, in COVID positive patients. So it's really, I think, the role of screening, of preoperative detection with imaging is something that we should pay a lot of attention to.
Thank you, Kathy. Yes.
Yeah, I'd just like to ask the panelists, which of the among the panelists has an experience already in the OR and wherein one of their teams or maybe a team member got exposed or was eventually got COVID positive later on because they did an OR? Anyone from the panelists?
Jeff, negative patient o negative yung healthcare worker?
Yung healthcare worker.
Negative, tapos the patient is negative.
Yeah, but
Eventually,
eventually, yeah, meron bang nagkaroon ng experience ng ganun?
I had one which made me go into quarantine because I did a colonoscopy on a patient who presented with hematochezia. So findings during colonoscopy was a tumor in the rectum. But during that colonoscopy, I was wearing a surgical mask, and I was wearing my, of course, my eyeglasses, and then a isolation gown, and just one pair of gloves. So that's the protection that I had during that colonoscopy. But my assist, my fellow, was not wearing any, just the isolation gown, tas wala siyang mask. 2 days after this patient, or 2 to 3 days after this patient, had cough and had difficulty of breathing or restlessness. The relative was telling me this patient had anxiety but is becoming restless. But I was a little bit suspicious that this patient might be restless because he's having difficulty of breathing. Eventually referred the patient to IDS, and they did some testing, turned out to be COVID positive. So the following day, patient was transferred to ICU and stayed there for 14 ICU and was intubated and stayed there for 10 to 14 days. So my fellow, after a week, developed symptoms of diarrhea and myalgia. I did not develop anything, but I had my swab done. I turned out to be negative, but my fellow turned out to be positive. So bottom line talaga, we don't know who they are and what's the presentation. This patient just came in because of hematochezia. I think there are certain GI symptoms or GI presentations of these patients. It can be diarrhea, and it can be actually lower GI bleeding. And yan, essential pa rin. Bottom line, if you don't know anything, protect yourself na lang. So a higher level of protection would be essential for an endoscopist because highly aerosol generating procedure ang endoscopy.
Thank you, Ray. Now I can give the mic to Maki. Please
Thank you,
unmute.
Mon.
Yeah.
I just like to comment on what Juvie mentioned, yung new normal, no? So, first, there is a joint paper published by ACS, the Nursing Association, Anesthesia, and the American Hospital Association, which is a very good guideline as to what to do post ECQ or post COVID. As all of the panelists mentioned, the main aim is really to protect you, protect your co-workers, and protect the patient. So, as lumalabas dun sa chat box, all COVID or all elective cases, if you plan to do electives, sa PGH will do testing for all, no? And then for our OPD consults, we are considering appointment systems, walang walk-in. So it has to be appointment systems, and everything has to be scheduled, and everything has to be planned before you bring in the patient. Now, with regards to the patient, there are two things that you have to consider. A negative PCR test does not mean that your patient is COVID negative. No, pwede pa rin kasi may 30% error ang RT-PCR. So you have to combine the RT-PCR with the possibility of a chest CT plus clinical. So just plain auscultation if there are no RALs. Some clinicians would say that if your patient has RALs, then that's already a possible COVID suspect. So everything has to be considered, and you have to protect everybody. And one thing that you have to remember is that there are legalities involved. If your elective patient, proven COVID negative, asymptomatic, develops COVID after the surgery, then was it a delayed manifestation of COVID, or was the COVID infection incurred in the hospital? So kasama yun sa preparation, yung legalities. You have to talk to the patient that there are possibilities of acquiring a COVID infection in the operating room as well.
Thank you, Maki.
Sorry, ma-follow up lang, Maki. Are
Yeah.
we, doctors and hospital, liable if the patient complains that he got the COVID when he had a surgery?
That's I'm not a lawyer, but
yes.
Remember, that can be a legal aspect that we have to discuss with our medical legal colleagues, no? Kasi sa guidelines sa US, that's part of their guideline now. You have to discuss to the patient the possibility of acquiring a COVID infection in the hospital. Kasi you don't know naman, even as I mentioned earlier, even wearing that 3M reusable mask, no, you may actually put out a virus through the exhaust valve if you don't cover that exhaust valve with the filter as well. So any healthcare worker, whether nurse, anesthesiologist, your runner, anybody in the operating room can actually infect a patient, no? So I'll give you an example. I'm looking at current statistics of PGH. You know, PGH is a COVID center. Our latest statistics in terms of infection of the healthcare workers, there are, despite simulations on donning, doffing, everything, proper PPE use, all of the PPE used in our COVID wards are approved by our HICU. Despite that, there are 2 doctors and 10 nurses who still got infected. So you really have to look into the possibility, as Kathy mentioned in, I don't know whether Kathy mentioned it in her lecture, the devil is in the details of the donning and the doffing. And majority of the infection is not acquired while you are exposed, but acquired during the doffing.
During doffing, that's right.
So would you recommend, Maki, that we should now have a supplemental consent that to include that patients can also, there's a risk for patients to be exposed in COVID once they go to any surgical procedure?
Well, the guidelines that I have seen only mentions that you have to discuss it with the patient.
Then
So
maybe
I think
written discussions, like a consent slip.
yeah, well, I don't know, but I think this is one thing that we have to raise with our medical legal section of the hospital.
Yes.
Okay. So
So yes, I agree with Maki. That is the reason why it has to be emphasized in our institutions, the multifaceted approach or multi-layer approach in protecting the healthcare worker. Donning and doffing is really the culprit there. Is one of the layers or one of the facets in the creation of that safety, and everything else should be combined, multifaceted approach to ensure the safety of our healthcare worker. And I think that's a very important point that you raised there.
Yeah, I just want to mention, Chito posted in the chat that according to the latest PCS guideline, explicit patient consent should be secured for the procedure, including the possible risk of hospital-acquired COVID-19 infection during the duration of the hospital stay.
Mm-hmm.
Yes, that's the informed consent has to be modified, and that should be included. It's also included in our guideline in PAHPBS on the informed consent of the patient on risk of exposure to viral transmission during the surgery and during the hospital stay. And in fact, something also that I failed to mention because of time constraints is the post-operative management, that you have to advise your patient to also be on home quarantine for at least 14 days post-discharge. So that is something that we always forget when we have discharged the patient. Parang we just discharge them, just so. But we need to inform them also that it is advisable for them to be on home quarantine for at least 14 days because they are still very vulnerable. They're a very vulnerable population.
Okay, thank you, Kathy. Kuya Maki, can you answer, please? There has been a recurring question. If your patient is a PUI or a suspect and turned out negative, would you downgrade your PPE?
That's a very difficult question to answer. But if you are really sure that the COVID status of your patient or your patient is unlikely a COVID patient, then at the very least, you do a level 2 as lectured by Ray. So still wear your goggles or face shield, 5 mask, waterproof sterile gown or a water repellent sterile gown, or you might use a water repellent gown over then your sterile gown, and then double gloving if you want, if you need be. No, so that's
Okay.
for the patient and for you. But again, when you doff that particular gown and your particular PPE, whether it's a level 2 or level 3, you still treat it as a contaminated PPE so that you will prevent infecting yourself. So there is a step-by-step approach as to
Doffing.
how to do it, whether level 2 or level 3.
Okay, thank you, Maki. So it's already late. We just want to get another opinion from our nurse, Miss Joanne. Can you give us your opinion, your perspective as a nurse?
Alvin, paki-unmute.
Paki-unmute si Joanne, please.
Na-unmute ko na. Yan.
Nakamute pa rin siya, Alvin.
Ma'am, pa-unmute na
Sorry,
lang kasi baka nadodoble. Yan.
Yeah, Joanne.
Yeah, hello. My internet is getting on and off. Sorry, what? Here.
Joanne? I think her internet.
Yeah, I can't hear you. Yeah, the internet is unstable. Sorry.
Network connection.
I hear you.
Sorry, I can't hear you.
Okay, so we have a.
Yeah.
Joanne, can you turn off your video so you can have a better. Joanne?
Joanne, turn off your video instead.
Dr. Mon?
Okay. Okay. Sige. Ray, you can you have the mic.
Before Ma'am Joanne, siguro I just like to add something dun sa what Dr. Filona said with regards to with regards to the doffing. So I think it's very essential that the staff would practice the donning and doffing of these PPEs because there's a study published wherein the perceived proficiency of the healthcare worker with regards to the donning and doffing does not actually correlate to the practice wherein when it's time for this healthcare worker needs to don or doff the PPE. So kailangan talaga there has to be practice every day or before. Sometimes what we do with our residents, we check if they are knowledgeable with the donning and doffing. If they don't know it yet, we have a mock PPE there, and then we let them practice. So even the spotter is trained every day, if need be.
Okay. So, Dr. Salud, can you give us your comment?
No, I was just saying, I'll just say whatever I want to say during the closing remarks. Go ahead. Tuloy-tuloy lang. Tuloy lang. Question and answer, open forum. Go ahead.
Okay, so Joanne, are you okay now? So I think she cannot connect. So any more questions? I think we have discussed a lot and it's already late. So...
overtime.
And Mon, ano naman eh, some of the
Yes.
questions were already answered by the
Yes.
panelists. So it's good that we do have a continuous people answering the questions. Yeah.
I think there was one last question about the cancer workup. When to do the cancer workup. I was just not certain what exactly the question was pertaining to. Was it probably a pre-operative workup, I think, for cancer? Something that I experienced, I can only share what I have experienced on these patients since they're mostly cancer, is that while waiting and since their cases were canceled, we monitor them weekly and make sure that everything is still within a safe period of time. I'd have the time to expound on safe postponement period, but this is what we do on the teleconsult, at least having a telephone conversation, check on your patient, what is happening to them. Communication with your patient is really, really important. That includes also all the extensive explanation on the possibilities, on the prognosis, on the possible canceled operation. Even if you have worked up the patient prior to surgery, but any time just before the surgery can be canceled. We advocate doing a repeat chest x-ray just before the surgery, or the day before surgery, or the night before the surgery, even though the patient already has a CT, because sometimes they had their CT a week ago. So definitely a repeat chest x-ray is necessary before the surgery. We cannot take chances, and this has kept us on the workups of the patients, the cancer patients especially, awaiting surgery, while we have to source out for blood because the anesthetist, the OR, doesn't allow any surgery without blood. So while waiting for all of these, sometimes the time frame for their preoperative workups are lapse. So we need to repeat them just before the surgery. So that's
Thank you,
what I
Kathy.
want
Yeah.
to answer for that particular question.
Thank you, Kathy. Okay, so any more comments? You want to say something? None? Okay, if none, yeah.
Yes, Mon, ano lang. So I just want to emphasize only from my lecture that the objective of all of these things that we are saying is to mitigate the risk of exposure and transmission. It is not a 100% guarantee. So what we want to do is mitigate the risk to lessen the risk of our healthcare workers in the operating room in terms of exposure to the disease or even transmission of the disease. So that is all I want to emphasize. Thank you.
Okay, thank you, Ike. So at this time, may I now call on the president of the PCS, Dr. Jose Antonio Salud.
Good evening, ladies and gentlemen. Thank you for this opportunity. First of all, I'd like to thank everyone who attended this webinar, who are joining in and listening in on this very important webinar. But first of all, I'd like to thank Dr. Boy Tan and the Board of Directors of PALES, as well as, of course, Kasite and the Board of Directors of the Philippine Association of Hepatobiliary Pancreatic Surgeons. And our two other speakers, Ray Sarmiento and Ike Mendoza, for very comprehensive and very informative lectures. I'm sure that these discussions we had tonight will help us in our planning for all surgical services throughout the country. And there is no doubt that the information we received will serve the surgeons, all the surgeons in the country well, more so in the coming days and weeks as we fight this virus. Because we started the webinar with a prayer, I'd also like to end it with a prayer. And please join me as we remember that we are in the holy presence of our Lord. Lord, your word promises that you will refresh the weary and satisfy the faint. Your word nourishes the root of our hearts, helping us bloom in the desert. Your love revitalizes us when circumstances threaten to dehydrate our faith. When we are surrounded by the dryness of uncertainties, fears, or change, saturate us with your presence. Pour your peace into every fiber of our being until we radiate with resilience. No matter where you have us planted, help us bloom for your glory. We love you, we need you, we praise you. Amen. Mabuhay ang PALES and at PAHPBS. Thank you very much for this webinar.
Amen.
And stay safe, everyone. Keep healthy.
Thank you.
Thank you, Dr. Salud.
Thank you.
Okay, gentlemen and ladies, that concludes our webinar conference for tonight. Stay safe always. Congratulations, everyone. Good night.
Would like to thank Alvin from Department of Science and Technology for DOST for assisting us. And we'd like to thank Medtronic also for our sponsors. Thank you and good night to all.
Thank you.
Thank you, guys. Good night.
Good night. Bye. Thank you, everyone.
Bye.
Thank you. Bye.
Alvin, stay muna tayo.
Pwede ba mag-inuman dito?
Off na natin, Alvin, yung yung sa attendees.
Payat.